and get started. As promised, we have a guest lecturer today. So today's routine, we will have our guest lecturer, Christina, and then we will have break, and then we will be returning your grades. During break, during break we're emailing the feedback sheets, and we have feedback rating sheets, and then also we like to put comments into your documents, so you should have 2 attachments to the emails. And we'll be meeting then after break, and you've had a chance to take a look to go over a little bit of feedback, global feedback for everyone, and then being able to take some time for Melinda, Lee, and I to be able to meet with your groups to answer any questions based on that feedback. So, any questions before we get started? Yeah?
Housekeeping, and
yes.
laptop in front of you, please close it. And if you pay full attention to our speaker.
So this information will be on the channel?
No, not specifically.
But it will make you a better professional.
I believe it.
We can hear
And
you.
overall, conceptually being able to apply for things, but no, we're not going to ask about slide 10 and exactly what data point that Christina shared with us. And the slides are up. If there's anything that you guys see that you do want to find for the slides, they're already posted on Blackboard, so they're available for you. Okay, so I would have the distinct pleasure of introducing Christina, and I'll do her formal introduction first. She currently serves as a public health analyst for the Overdose Response Strategy in South Carolina and is employed by the CDC Foundation. She previously worked as a project manager at the South Carolina Department of Health and Human Services, so DHHS, that we sometimes talk about. And she's also a 2-time appointee to the City of Columbia's Bicycle and Pedestrian Advisory Committee, so a range of experiences there. She earned her dual master's degrees in public health and city and regional planning at the University of North Carolina at Chapel Hill. She's focused on the intersection of health behavior for transportation planning through research and practice in the areas of active transportation, traffic-related injury prevention, and transportation to medical services. She received her bachelor's degree in journalism and mass communications from USC, go Cops, and she also completed her Fulbright English teaching assistantships in South Korea. In her free time, she enjoys hiking and road biking challenges, and her most recent was a bike trip from Atlanta to the Alabama line over Labor Day last year. And done a lot of hiking trips and a lot of other adventures. Not in her bio is that she was Lee and I's first intern at that little organization that we've mentioned before, the South Carolina Public Health Institute, which she joined us her senior year. At USC through the transition and rebranding and communications around to the Institute of Medicine and Public Health. So Lee and I have had the pleasure of knowing you about 10 years now through a lot of your journeys, and I know you've worked with Melinda as well. So it is always a pleasure for Lee and I to welcome back students we've worked with. And when we talk about how we're working with y'all and we look forward to working with you in the future, not just in this dynamic, we truly mean it, and we love staying in touch and being able to continue to do good things in South Carolina. So, thank you.
Thank you so much.
Oh, thank you for the warm welcome, and I really hope this can be a conversation today to tell you a little bit about my pathway and hopefully some lessons learned from my experiences. I wanted this to be a little bit interactive. There isn't too much thrown in there. I know your laptops are closed, but with your cell phone, if you'd like to join the poll everywhere, so you can go to pollev.com and enter CG718, or I believe you can also text to enter. I've just got a couple questions sprinkled through for some interactive dialogue, but if you don't participate, can't get it up, don't have a smartphone, that's fine. Just to get started here. While you're doing that, I wanted to share, and Megan gave a sneak preview, that I've really had a winding journey in my experiences in public health. And I think public health is really a degree that's very versatile and allows you to be very curious. So she described, I started out in journalism, I did a little bit of teaching, then I did my master's in public health, added city planning in there, I worked in healthcare, and now I work in overdose prevention. So I don't even know what's next, but I know that my public health degree has really prepared me to do a lot of different things. So the first question, and again, the website is there on the top. I'd like to hear about what public health topics you're most passionate about. And if this errors out on me, then we'll just keep moving on, but hopefully it works for you today. All right, infectious disease, maternal and child care, health disparities, physical activity and maternal health, mental health, childhood obesity, physical activity and equity, rural health care access, social determinants of health. All right, some fantastic things. Couple infectious disease folks. The next question, I'm not sure if a couple people already moved on to this question, but what public health skills are you most interested in exercising? Program planning, program management, evaluation, other, or don't make me choose one?
You do not have to pick planning. We won't know. It's fine.
It's anonymous.
But we would be sad if no one chose.
Yes, that's true.
No grades will be contingent on this information. But we do have a lot of folks interested in planning, so that's very cool. All right, so today's theme, I'm going to share two different aspects of my personal and professional experience related to public health. First, my civic engagement in the Bicycle and Pedestrian Advisory Committee and how that bridges public health and city planning for walking and biking and active transportation, all the benefits that come along with that. The second is my current professional experience in the overdose response strategy, bridging public health and public safety for overdose prevention. And some things that I want to try to talk about are how we collaborate across those fields, and then also how we gather data and evaluate how well we're doing on those goals. So the first one I'll talk about is BPAC, or the Bicycle and Pedestrian Advisory Committee for the city. So first off, a little bit of the research behind it. And you probably are well aware of the connections between active transportation and physical activity, and that there are often some disparities in access to active transportation modes and to the things in our community that can make us healthy, like opportunities for healthy eating and grocery stores. Some numbers in Columbia. We have a relatively small percentage of trips that are made by bike in Columbia, but actually a fair number by foot, and I would attribute some of that to the fact that we have a university community here. We know that if folks walked and biked more, they would be able to reach their recommended allocation of physical activity every week much easier. And it has some benefits economically for the community as well. If people walk and bike more, they are more likely to engage with the businesses and services around them rather than just flying by. And unfortunately, we also know that there's disproportionate burden of the negative health outcomes from injuries related to traffic fatalities among underserved communities. Here are some examples of some data that was collected through the Bike Walk Master Plan process for the City of Columbia. And you can see here that people rated walking conditions at the time, that was in 2015, to be fair, spotty sidewalks, fair bicycling conditions. And when they rated their top three transportation priorities, it was to expand the bicycle network and construct more sidewalks, not to add more roads and highway lanes. So that was a little bit of the context. And then let's talk about some of the principles around active transportation. So one is the safe system approach. And this is that everyone can make mistakes when we're driving, but we can make the environment more conducive to safe driving, safe walking, safe biking to reduce the risks that may be inherent in using transportation. And changing the culture is still important, educating people about how to drive or bike or walk safely, but it's also about changing the conditions and the environment for them. The gold standard is also to achieve complete streets. So a complete street is one that enables safe access for all users across different transportation modes, whether that be walking, biking, whether they need ADA accessible sidewalk ramps. Everyone can use the roadways very easily, and it accommodates them. We are fortunate that last year DOT actually adopted a complete streets policy statewide, such that if there is any plan at the local level that applies to a DOT street, they have to consider that when they're doing resurfacing. So that allows us to have more opportunities for biking and walking infrastructure to be put into place. South Carolina actually has a very high percentage of our roadways that are state-owned as opposed to locally owned, so that really does make a difference. And then some guiding documents for Columbia. First is the Walk Bike Master Plan. So I described some of the data that was pulled together in 2015 for the creation of that plan. And we also have the Public Space, Public Life Action Plan. So we brought in a consultant for this and did some observations of how people use public space in the city, which can also inform their ability to walk and bike and to feel safe and secure in using the environment. So these are two guiding documents that inform some of the changes that we make to the city. And I wanted to tell you a little bit about city plans. If you haven't read one before, this is the structure of our Bike Walk Master Plan, and there are some things that kind of align with a program plan that you might make in public health. For example, starting out with some existing conditions, kind of like your epidemiological assessment, gathering some input from the public about changes that should be made, and then assessing and making recommendations for different changes in infrastructure as well as policies, and then matching that to potential funding sources. So definitely interesting to take a look at these if you haven't before. And all of what I've described hopefully hits home to you with one of the major theories that relate to you with public health, which is the socio-ecological framework, right? Policy, systems, and environmental change, and that it takes both the change at the environmental level and at the cultural level, which I think is really the place that the Bicycle and Pedestrian Advisory Committee comes into play, how we can help make these environmental changes fit and to promote the culture change needed in Columbia to pair with that. So BPAC consists of 17 members that are appointed by council. They must either live or work in the city of Newberry, and they represent different community and neighborhood interests. Some of them are connected to businesses. We had someone with Blue Cross Blue Shield because they sponsor the bike share program, the Blue Bikes, which hopefully you're familiar with. Some representatives of neighborhood associations, DHEC, the Comet, and we meet the second Monday of every month, so we just had a meeting yesterday, generally at the public library at 4:30, so you're welcome to sit in on those. They're open to the public. And our mission for BPAC is to advise the city about the changes they make and the issues that are pertinent for walking and biking to citizens in the Columbia area, as well as to help develop and implement initiatives to help promote active transportation in Columbia. So I'll highlight a couple examples of those types of initiatives that have happened. We, prior to the pandemic, had Handlebar Happy Hour, where we'd have people bike together for a happy hour on Divine Street and also have guest speakers talking about different projects related to biking. We typically have Bike Month activities in May, which will be happening this year as well. Walk to School Day in October, so we did that at Logan Elementary. And even during the pandemic, we had a walk bike bingo that parents and teachers could help encourage students to do at home, even if they weren't actually going in person to school. So some examples of current activities. One is the Explore Freely campaign. So I encourage you to follow the Bike Pedestrian Advisory Committee Facebook page. Right now, each month, they're posting different walk opportunities in the city. I think this month it was a romantic walk. In October, they had one for Halloween that was a cemetery tour. So check it out and just see what places you haven't explored in Columbia. We've also recently started the Walk Bike Ambassador Program. So the advisory committee is 17 members. We're volunteers meeting with the city. We have a very interesting balance in terms of not being a nonprofit with a bunch of membership and not being voting members of council that can completely enact change. So one thing we identified was the opportunity to create a larger network of people in Columbia who can help promote safe walking and biking in their communities, can help garner more interest in these projects that are done by the city, and to also plan different initiatives within their own communities. So in the fall, we held our first session. It was a 5-week class session with guest speakers, as well as some group activities, a group bike ride on the Blue Bike system, and a walking assessment, where they were observing different aspects of the environment, whether the sidewalk condition was good, and kind of reporting back to us on that. And we hope to, in the spring class, have them create a specific goal that they want to work on, whether that's a environmental change in their community or starting a certain program like a bike rodeo for children, where a mock street setup is set up for them to practice biking in a safe environment and stopping at stop signs. So we really want to elicit their interests and have them create things that meet community needs with our support. We're very excited about that. The last one I'll highlight here is the Open Streets event. So we held this one from 2016 to 2019. Took a pause during the pandemic, but we are grateful that Earlwood and Elmwood are planning to host us again this year. Open streets are an international phenomenon. It is where a street is temporarily closed to cars and opened up to people. And so it becomes a space where people take over it and re-envision what this pavement space could be used for in a more active way. So you can see here on the right, I know this is kind of small text, but we generally have different themes for open streets. In the past, we had one that was focusing on fitness and wellness, sustainable transportation, kind of promoting civic pride as well. And different, what we call activity leaders, would have set up different engagement opportunities on the street. So for example, this is from 2016 to 2018, we had open streets on Divine Street. So you can see here there were some fitness classes. We had some people practicing paddleboard. The bike patrol was demonstrating some skills, a yoga class, some dancing. So really getting people to envision, what it's like when the street slows down. People notice the businesses on the side much more, as well as how much space we dedicate to pavement that could be used for activity for people. And we're very excited to bring this back this year. One thing that I want to talk about with both of the issues that I'm presenting today is culture change. And I think as public health professionals, we're really getting challenged to be better about not just educating, but helping folks change culture in a way that is promoting health for all people. One thing that I wanted to highlight, for example, with this issue is parking. We hear a lot of, there's not enough parking in Columbia. Well, there really is. If you take all the different parking areas in Columbia and put it all together, that is how much it would represent out of Columbia. It's just whether or not people feel comfortable walking wherever the parking was located and find that to be helpful to them. So some examples of ways that we might change the culture: incentives to park once. So the soda cap connector being a very low cost, at one point it was free, but a very low cost opportunity to get around the city very easily. We've also had parking day, where different parking spaces in the city are closed down for the day, and pop-up events happen in those parking spaces. You can actually see, I'm forgetting that intersection, but in front of the Columbia Museum of Art, I don't know if you've seen the little parklet where they took over one of those parking spaces. It basically came out of this effort, people saying, we would like more places to sit on the street, not necessarily another parking spot. What I was going to talk about next was about some of the data collection on how we're making change. So this is from a different city, but it's very closely aligned with what we're doing in Columbia with bicycle and pedestrian counts. So I wanted to play this.
Pedestrians of this corner.
So this is part of our biannual bicycle counts, and it's part of the National Documentation Project, which is a nationwide project to count bicycles and pedestrians like we do cars, to account for the mode shift, so the amount of bicyclists and pedestrians on the road. So when we have car counting, you know those little bubbles those strips on the road that you drive over. They don't count bikes and pedestrians. So we need to make sure that we have the data so that we can clearly define the amount of pedestrian and bicycle traffic we have to help us get grants, funding, and account for who's using the roadway. So we use this both locally and nationally, but it's important to include ourselves nationwide in that data collection because we're a rural area and we don't want to be forgotten in Washington, D.C. and up at the state capitol. We want people to remember that we're here, we're important, and we deserve to be eligible for funding just like anyone else. So we retain the numbers and we compare them to the U.S. Census, American Community Survey numbers, and the census numbers to make sure that we can see if we build a project, does it have an impact? And we've seen that it does. This year we have 77 volunteers. In order to get these counts done, we needed 77 volunteers to fill all of the shifts. So without our community volunteers, the multimodal ambassadors, I like to call them, this project would not be completed.
All right, so that is very similar to the way that data collection is done in Columbia. So we do annual walking and biking counts in both the spring and the fall. And that is very important to us for giving feedback on how different roads are being used, where we should prioritize implementation of new projects, because the walk-bike plan was made in 2015, but we know things have changed quite a bit even since that time. We do walk-bike counts on the road, counting the number of people, very similar on a sheet like they talked about. It is very time intensive and requires a lot of volunteers, so I will plug if anybody would like to do that. It's actually a very nice way to spend a couple hours people watching. But the public space, public life counts are also another one that we do, again, observing how people use the space and how we can continue to promote that. So these are all the different locations that we use for doing the public space, public life counts, inclusive of some locations at the university as well. And how this has fed back into some of the work by identifying some opportunities. For example, we observed that there was potential for the State House grounds to be seen more as Columbia's front porch, for people to go there and spend time on the grounds with the beautiful flowers, really enjoy that space and walk around. So we applied for some grant funding and secured these different lounge areas that could be set up at the State House at different times of the year for people to enjoy that space. We also saw the opportunity to have more areas for people to sit and enjoy lunch on Main Street that was not paying to be at a restaurant. So again, sought some grant funds to set up the tables that you see out on the street, and they set them up for Soda City as well for people, again, to be encouraged to walk on Main Street and to stop and to have lunch, to meet other people. And the more that this life is added to these spaces, encourages even more people to come and use those spaces in the same way. And then one other opportunity for evaluation. So a couple years ago with the Open Streets on Devine, we actually had a public health student for their graduate project work with us to do intercept surveys of folks who came to that event to kind of ask if the themes that we were trying to encourage were being carried out by the event. And this is a little bit small, but 2/3 of attendees became aware of a business that they didn't know about simply by slowing down and walking along that street. Many folks arrived by walking and biking and said that the opportunity to spend time there did increase their physical activity for the week. And a lot of people describing loving having that open street and community feel. So like I said, a plug for you to get involved if you're interested in this area of active transportation. The city will be looking for folks to volunteer for those bicycle and pedestrian counts, and hopefully one of those slots fits in your schedule. It's a lot of locations. You can find one near where your apartment is, perhaps. And then Tentative date for open streets, we may actually have to change that pending our application to the city for the permit, but that's what we're hoping. But at the very least, feel free to follow us on Facebook and you'll get up-to-date information. These slides will be shared with you afterwards if you can't take it down right now. All right, I'm gonna breeze right into the second half here, but hopefully I will have time for questions at the end. Looks like people are mesmerized so far. So still seeing faces looking at me and not lying down on the desk, so that's good. The second piece is the overdose response strategy. So this has been my area of work from January of 2020. So I came into this job right before the pandemic. And this is an opportunity to be bridging with our public safety partners, so a different angle of partnership. So as you may well know, drug overdoses are probably our second highest challenge behind COVID nationally. For the 12-month period ending in April of 2021, we topped 100,000 lives lost for drug overdoses. And we have seen different waves of this, this period of drug overdoses, starting with prescribing practices, really heightening the attention to pain and the overprescribing of opioids. As more measures went into place to kind of counteract the overprescribing, a shift into more use of heroin, and then even more recently, synthetic opioids, which don't have to be grown like heroin, becoming more and more prevalent in the drug market. And these are even more potent and deadly when they are used. Fentanyl, for example, is 50 times more potent than heroin and 100 times more potent than morphine. So someone who became addicted to a prescribed drug and has kind of continued to move through different types of substance use is now exposed to a much more risky substance that may lead to their death. Today, nearly 85% of overdose deaths nationally involve either a synthetic opioid, heroin, cocaine, or methamphetamine. So some important things to be looking at. So I described the three waves of the overdose epidemic in terms of prescription opioids, moving into heroin, and then synthetic opioids. I was wondering if you know what will be considered the fourth wave of the overdose epidemic. It may be having gotten out and glitched back in, but the answer here is stimulants, which is interesting because stimulants were much more prevalent in the western area of the United States and are really moving more to the east, and kind of the converse of synthetic opioids kind of starting this way and moving more towards the west. So provisional data from the CDC predicts that for the year of 2020, we will see more than 1,700 drug overdose deaths in South Carolina, which was a more than 50% increase over the previous year. And when we break that out by the type of substance, we can see that synthetic opioids here are primarily responsible for that increase, with around 100% increase over the previous year, so really astounding. And some key trends to note here are that we know that it became more difficult to access services for folks during the pandemic, as well as the isolation and the pressure that we all felt increasing substance use for many people. At the same time, that was compounded by the increasing presence of synthetic opioids in the drug market. And we know that it's very important to communicate about the risk of overdose to all communities. While many of our overdoses are in the white population, we have seen nationally an increase in African American and Hispanic communities at a faster rate than in the white and non-Hispanic populations. So it's very important to link all folks from different sectors to opportunities for treatment and recovery. So this is where the overdose response strategy comes in. So this is a partnership between the CDC and the Office of National Drug Control Policy to bridge partnership between public health and public safety, because we know our first responders are often the ones who are getting called to administer naloxone and are at a place to help respond to an overdose and also link people to different services. But they are not treatment specialists themselves. And so we really want to help get folks from those emergency situations into places where they can receive support that they need. The overdose response strategy is focused on bridging these two sectors around information sharing as well as implementation of evidence-based and promising practices. So some different ways that we do that are promoting collaboration as well as sharing data. So public safety data, public health data, it wasn't always communicated very well or very quickly across those two sectors. And also helping different communities create solutions that are tailored to their unique assets and the partners that they have in play to help address the situations that they're seeing in their communities. All right, so some examples of the different strategies that I wanted to share with you. One example in terms of sharing data is a tool called the Overdose Detection Mapping Application Program. This is a national program that is open to public health and public safety entities to use. First responders are able to plot points for an overdose that they respond to. It does not have any personally identifiable information. It's just marking a location, and you can't actually get to the street address number. You're just kind of seeing the general area. But you have the ability to set spike alerts. So if the number of overdoses within a 24-hour time period reaches a certain level, it will alert people to this information. And these stakeholders can then send out alerts to other communications networks to let people know that there may be a particularly potent substance in the community, or there's additional need to really make sure people are getting referred to services. Some examples of some of the evidence-based response efforts that we can do, and the overdose response strategy is now expanding nationally, so there will be a public health analyst, which is my role, and a drug intelligence officer, who is the representative for public safety in the state, in each state, working together to bridge these different partnerships. So we're both working together on these efforts with our respective counterparts. Some evidence-based strategies that we work on include trying to target naloxone to different areas that are in high need of that resource, a life-saving drug that can reduce an overdose that involves an opioid. Increasing access to medication-assisted treatment, helping people understand if they call 911, there are no repercussions for seeking help for someone that they're responding to. Naloxone distribution and treatment centers in the criminal justice system. So I'll highlight here in South Carolina, we're piloting a program to distribute naloxone to people when they're returned to the community from jails, because that we know in the 2 weeks after someone is at release, they're at much higher risk for overdose. If they had used substances previously and they're returning to the community, again, the presence of much more potent substances and maybe not having a great support network as well as starting programs in the emergency department and syringe service programs, which are limited in South Carolina, but again, something that has been supported as an evidence-based practice nationally. And then some promising practices. So this is where maybe the evidence is not there yet, but we are working to test and to refine these strategies, particularly with our public safety partners. And many of those happen with linkage to care opportunities. So you can see here the CDC reports that more than 3 in 5 people died from an overdose who had an opportunity to be linked to care, and that just didn't happen for them. And we know that our public safety partners, EMS, a coroner speaking to a family member who may also have a substance use disorder themselves, or law enforcement have opportunities to link people to these services, but they may not even really be aware of all those networks. So making it even easier and doing more warm handoffs where it's not just a referral card to someone, but they actually get an appointment or someone makes a visit to them afterwards. So some examples of programs, and I'm sorry this may be dark and a little bit hard to read in the back, but I'll go down to post-overdose outreach programs. We do have some that are led by EMS and by law enforcement in the state, where they go with a peer support specialist to someone's home ideally within a day or two after their overdose, to do a kind of wellness check on them and to offer services and link them to care. We also have some efforts in the state to do overdose fatality reviews, where you're not just reviewing the aggregate level data through something like ODMAP, but this is where you're doing a case review in a confidential setting with a group of stakeholders that have data on this person from many different touch points, and an opportunity to identify gaps in our systems within and across communities for opportunities to prevent future fatal overdoses that would be very similar to that one. And then we do have the opportunity to work in primary prevention, but I will admit most of my work is more on that kind of secondary, tertiary end of prevention. But we do have the opportunity to do communications, to work with school-based programs, and again, public safety partners can be involved in those as well. So how do we evaluate all of that effort? One of the data sources that the state has put together through the Opioid Emergency Response Team, which is the collaborative group for all state agencies around opioid and overdose response, is the Just Plain Killers website. And it has an opioid data tab on there that includes information across many data serving organizations, whether that's DHEC, the Department of Corrections, Medicaid, and they have those dashboards by the counties as well. One other opportunity that we're working towards in South Carolina to gather more data is through funding with the CDC and the Overdose Data to Action Grant. So this has some components for gathering better data across different stakeholders, and this is funding that goes to DHEC, but working on improving data collection from emergency departments. They have a great innovative surveillance project where hospitals can send samples from overdose patients to the public health lab, and they will test for the presence of fentanyl. And some improved prescription drug monitoring program work, as well as collection of toxicology and death certificate information. And then the sweet sauce is really putting that data to action. So how can we use all of that information to focus our resources, particularly for all of those evidence-based and promising practices, to the areas that need it most? So one example of focusing those resources that I wanted to talk about is one effort that's really close to my heart, which is a rapid response team at the state level that we set up actually in April of 2020, which was a really important time for us to be looking at data very closely in the state. We got a subset of the opioid emergency response team, that governor's task force, to meet together on Wednesday mornings for 30 minutes to review the EMS data for the state and identify different areas that were seeing more heat in their activity over the past week, and to make sure that we could synchronize resources, reach out from the state level agencies to the local counterparts to make sure they had everything that they needed. So one example of how this worked for us was in Marlborough County in 2020. We noticed that there were, this is just an example, but 2 different hotspots in their community. And it was actually in one of their major towns and in an area outside their major town that they didn't really expect to see activity. So we let them know about that. They planned a drive-through Narcan distribution event, and they shared more than 60 doses of Narcan with their community, which Marlborough is very rural, so that was actually some great penetration of that resource into the community. Some ways that we evaluate that effort, I find that it's often very hard to connect that specific effort with saving lives, but it's important for us to know how it's operating. Some ways that we measure that is the different numbers of outreach opportunities that we have, how many different data sources we're bringing together to the table, and different policy, process, and program improvements that we make. We want to try to move towards not being as reactive, but being proactive as we identify opportunities to get ahead of the trends. And then in terms of some longer term outcomes, I think we've really gotten a better sense for overdose trends in the state from this real-time, ongoing look at the data. And there has definitely been some opportunities for increasing the targeting of our resources. DHEC has applied for grants in specific areas that we've seen continued hotspots or spikes and have continued to need more resources in those areas. We've also seen increased naloxone distribution across the state at the same time. And we have seen anecdotally in some areas where we've done these alerts that there are fewer overdoses in the following months, although that may also be related to the drug market in the area. And one final project I wanted to share about, through the overdose response strategy, we have the opportunity to seek funds for pilot projects. So again, this is more of that promising strategy, innovative approach to things. And South Carolina was the recipient of one of 4 grants last year for a pilot project and received an expansion grant this year as well. This was for a post-overdose outreach program in partnership with the Courage Center, which is a recovery community organization in Lexington. And innovating on the traditional model of going in person to visit someone 24 to 72 hours after their overdose, they actually injected a bit of mobile technology into it. So when EMS responded to a Narcan responded to an overdose and administered Narcan, they would provide someone with this core care pouch, is what it was called. And it included a cell phone with prepaid minutes, and it was already loaded with a text message from a recovery coach. So they turned the phone on, and this information was there, and the recovery coach would actually call that cell phone directly within that window directly after the overdose. So in the first year of the project, they were actually able to reach 1/4 of the people on this cell phone that they had provided them. And then for those that they were not able to reach via phone, then they would do a home visit. And with both of those strategies, we're able to reach 38% of people. I think when you combine contact with a family member, if they went to the home and they didn't reach the person, it was about half of folks. And this is really important because it's time intensive to make a home visit. You may not reach everyone all the time. And trying to get them connected directly with a recovery coach and kind of release the burden off our public safety partners. So in the year 2 of the grant, we're hoping to innovate on this further, have some reinforcement through the hospital for this referral source. They're also moving to a text-based platform such that if folks already have a cell phone, they could scan a QR code or text to go ahead and start entering and engage with a recovery coach directly that way. But really proud of that effort with our local folks. So I just blew through some completely different perspectives, but I think there are some commonalities here. And one is that it's really important for us to know how to partner with different fields that have some common objectives with us, because it's very important to have that collaboration to help move the needle on some of our most challenging public health issues. It's also very important to be listening to the data as locally as possible, to pair it with the research and best practice. You can innovate on the evidence-based practice too, and then to take action in those areas to see change. And the last bullet that I didn't include, again, is that these issues are challenging, and I think public health professionals are really having to learn how to adapt and how to speak to communities, how to frame things that are beneficial for our health, and to move past stigma for some of these issues. And as much as you can learn and be trained in health communications, I think that's really important to be successful going forward. All right. That may not work, but you're welcome to raise your hand if you have questions about any of those things or something else that I didn't talk about that I mentioned having done.
I'm going to actually ask questions the old-fashioned way.
Yeah, go ahead.
Back to the bicycle and pedestrian committee, what changes would you like to make in Columbia to promote more bike usage? Like if you had grant money or something that you got, what would you do?
More bike usage. So we have talked about trying to do some pop-ups like putting a bike lane on Sumter Street and testing it out, seeing how well it is utilized. So I think we would really like the opportunity to do that, and that probably wouldn't take too much, actually. Right now, the City of Columbia does not have a line item for walking and biking projects. So unfortunately, that means they have to kind of seek out different grant funds over time. What we have continued to advocate for with council is to put in a line item for biking and walking projects so we can make consistent progress against our walk bike master plan, because that's what other cities like Greenville have done, and they've really seen the results. So that's my pitch.
Yes, in the back.
So a little bit of a selfish question. So I'm from Belton, which is a very rural community. And then our group project for this course, one of the barriers that we're trying to plan around overcoming is stigma for HIV. But I know for drug use, it's just as tough to talk to your neighbor about that kind of stuff. So I know that the provision of the phone is a great way to get around kind of the getting people to contact a recovery coach. What are some other strategies that you've seen used whenever it comes to overdose prevention with getting around that social stigma or that the feeling of shame about it that people may not reach out for recovery?
That's a really great question, and I don't know that I have all the answers for that. I definitely think when working in both HIV/AIDS prevention and overdose prevention, the community organizations that have the network, the recovery community, is very close to the ground and understands how best to reach folks who are, because they're coming from where they are. So I really defer to our partners at the Recovery Center, the Courage Center, about how to connect best with people in their shoes, that they walked in their shoes previously. And they're actually working on a documentary and have done an anti-stigma campaign specific to overdose prevention, but it's really about kind of eliciting that it is a disease, but we can move past it, and support is out there. And it's important for us to see also leadership from members of that community as well, and to recognize how successful they can be, that it's not something to be ashamed of or something that's hidden away, but it is a part of our communities that we can work together on. I don't know if that really answered your question, but it's very challenging.
Yeah, no, I was just thinking of, especially in rural communities, even if access is remotely provided, if it's feasible based on transportation issues, social stigma, as well as, somebody may not want their family member that they live with to know that that they've experienced an overdose. So I'm always just kind of curious what kind of methods are used around that.
And I would say when the recovery coaches were calling up these individuals, they often had a lot of other needs beyond that, and it was important for them to get those needs met first before being able to meet their kind of health treatment needs. I need to be able to get to where I need to go. I don't have a house. That's the most important thing to me right now before I get treatment for something. Yes?
I did a field practicum last year at the Dalton Center, which I don't know if you know about it, but it's like a substance and alcohol abuse center. And we noticed the big thing was mental health and substance abuse go hand in hand. So I was wondering if you all have any strategies to tackle both with what you're doing. Especially with COVID, it's really been a rise in the mental health and substance abuse.
Yeah, absolutely. I think definitely on many of the task forces and coalitions, it's really important for us to have both of those together. I've been trying to have some conversations about how we could better share data even with the mental health agencies to understand, because they also have crisis calls, and maybe there's some correlation there that we should know about, making sure that we have referrals, pathways that can get people to both types of services and both types of services if they need both of them. And with overdose fatality review, they can also review intentional and unintentional overdoses as well to kind of better understand the factors that were at play for that individual. Those are just some examples, but I agree that's an area that we need to be working even better on. Sorry, you, and then you, and then you. Okay, yes, sorry, go ahead.
So what are some of the evaluation indicators that you use for your program?
Sorry, evaluation measures?
Indicators.
So, I think the longer term outcomes for overdoses specifically, certainly fatal and non-fatal overdoses, but before you get to that point, certainly whether folks are being linked to treatment, naloxone access, we know that those are the precursors or the things that we need to move the needle on before we would see a change in actual morbidity and mortality. Yeah. In the blue shirt. Sorry, I don't know names.
No, it's all good. So I know in a lot of cities, going back to what you were talking about with parking, a lot of the discussion is around, yes, bike lanes, but getting rid of parking and building density by using the zoning code is an incredibly important tool. How much of a discussion around that is happening in Columbia, at least from your perspective?
Very good. So transportation and land use is very important to go together. And we did have the opportunity as BPAC to review the update to the zoning code, land use and zoning codes. I'm forgetting the name of that document, but we did do some review of that to kind of identify some areas to expand the thought about promoting active transportation and land use that was better connectivity. So I don't know that that's the way that we come about it, but we do, and the city is thinking about that as well. Yeah.
Okay, yeah, that just the density, it seems so, building density seems extremely crucial to actually achieving the, a number of people who would be utilizing bike lanes in the first place. Because one of the things I always see people complain about is, well, there's hardly anyone biking. Why do we need a bike lane? Which, it's part of the problem. So that's interesting. Thank you.
Yeah, and infill development. Unfortunately, the lollipop style neighborhoods that were popular are not the most conducive to those types of things. But as much as we can fix the new things that we do, trying to do that.
Working.
Yeah. So are you teaching people how to use the naloxone, or are they just being distributed to the communities? I know a lot of people get EpiPens, they don't know how to use them. Right.
So actually, the state statute in South Carolina requires brief education in order to distribute naloxone. So in some states, they have started putting naloxone in first aid boxes like AEDs. But I think what's holding us back in South Carolina, or I guess the way I interpret it, is that requirement of education, which makes it difficult to just sort of leave it in a place without educating somebody about it. But they're community distributors of Narcan. These are organizations that filled out a brief application with the state and got approved to distribute naloxone without a prescription. Many of them are the behavioral health treatment agencies like LRADAC, but there are some churches and community organizations that have that status. And the education training doesn't have to be very long. It could just be a couple minutes, and then they will give you some naloxone, no questions asked. They're also increasing distribution of fentanyl test strips as well. That's a newer tool that's being distributed. But yeah, definitely, I'm not sure where it's being distributed on campus, but there's probably an organization that's able to do that for you as well. Definitely learn how to use naloxone and have it. Did you have other questions? You had it written down.
No.
Okay.
Well, I have a question for you.
Yes.
So as we've been talking about in the introduction, we've known you a long time, and we've known you since your undergraduate days. So I know from our conversations that some of the work that you've been doing and what you've gotten into was not necessarily what you thought you would be doing. And as you referred to, sometimes the winding road with career pathways that all of us have. I was wondering, for the benefit of our students starting out with all their ideas, if there's anything you wish you had known or realized when you were in their position.
Wow, that's a good question. Yes, substance use and behavioral health was not my area of focus. I would not choose the projects on my current profession when I was choosing things in graduate school, but I love it now. It's personally important to me because my dad was in law enforcement, my husband is a volunteer firefighter, my mom was a nurse, so I just feel like I've inserted myself right where I belong right now. And so I definitely encourage you. I asked the questions at the beginning because I think some people focus really pointedly on a specific topic, and that's what they want to do end to end. And some people focus on a different skill that they really want to focus on, like program evaluation, and then they'll go from topic to topic on that. So you may just want to kind of think about which approach you want to take, and sometimes it takes eliminating what you don't like, but you may come back to later. And I think for me, the commonality was using data to help people drive decision making. That's what I tried to do even when I worked at Medicaid. I had a fellowship with the Government Performance Lab, which was looking at active contract management for state agencies and using dollars for social services most efficiently. So I think I've just continued to look for opportunities that let me do that in innovative ways and to help my community that way.
Thank you. Any other questions? Okay, well, let's all give Christina. Okay, see ya. Let me get out of the way of the email.
Feel free to email me if you have other questions, and please follow the BPAC stuff on Facebook.
And Christina did share PDFs of her slides, and they should be posted. I say should because we've all learned that just because I did something on Blackboard once doesn't mean that it took the first time, so let me know if they're not there, that they're up there and available. I do want to go over some housekeeping things and stuff too as Christina shuts down, so I'm not sure how long she's able to stay, but you have her email if you have any questions moving forward.